share it with us, we can help you develop it or modify it or change it in a suitable direction.
Okay,
it's okay for you, yes.
The one I was having it in my mind before was the use of magnesium sulfate as an adjuvant, for me to know how it can reduce the induction agent, the cardiovascular stability intra-op, and also the pain, post-op pain,
Okay.
opioid consumptions. But the challenge I am having, most of the study I saw that was done, there was no serum magnesium that was done. So I was thinking, if I want to still go ahead with it, there might be a there might be a requirement for me to do serum magnesium, and in serum magnesium is not done it's not common. So that's the challenge. But most of the study they did, there was no serum magnesium. So I was thinking it might be maybe my local supervisor or the assessor my request for that. So that was why I'm still not be able to take the topic to start working on it. So I was
let me just cut in because of time. Magnesium sulfate issues have been overplugged. I don't want you to go there. Don't even bother to go there. I supervised the candidate that did that magnesium sulfate. He went to and fro, the proposer went to and fro with assessors, and all these issues you're talking about kept on coming up. In the end, the research or the proposal was approved, the topic was approved, but he has done the exam twice now, and he has not passed. So when you, from the beginning, when you have a topic that is difficult, and you are the researcher, you're already seeing the pitfalls, the challenges, they are called confounding variables. You're already seeing it. Why do you want to go to a difficult area? You don't need that, okay?
Yes.
What are you interested in? Are you interested in pediatric anesthesia, obstetric anesthesia, airway management, neuro, cardiothoracic? You need to first of all identify an area of interest. Are you interested in regional anesthesia, maybe peripheral nerve blocks or central neuralgia blockade? What is that area that stimulates you, that gets you excited when you are doing anesthesia? That's what I want you to say. When you say that area, then we can begin to talk about topics, things that you want to know more about, okay? So what area are you interested, or what areas are you interested? We have just 5 minutes for you because we need to move on to other people. There are other questions on the chat box.
Like the neuro anesthesia, I was also thinking of comparing regional block, blocking the nerve that supply the scalp, to compare it with infiltration for patient undergoing craniotomy. But one of the criteria that I may need is to assess the post-op requirements after the surgery. So I discovered that in my environment, we hardly have patients that will have a better GCS, like GCS of 14 above, with maybe cranial tumor or abscess or skull depression, where their GCS will be better. The common one we have is traumatic brain injury, which will come with very low GCS, and post-op GCS2 will not be appreciated for me to use one of the scale for to assess the pain management. So I also try to find out whether I can get a scale to assess the post-op pain in the traumatic brain injury. Like the last time you presented, you mentioned observational pain score as well as the critical care pain observational scales. And you mentioned that these scales are not used for head injury. So that one become also difficult to assess the pain post-op based on the number of the type of patient I have in my environment.
Hello, Dr. Shaibu. You know what, you are still, I don't want to use the word stroking evolution, but what you're doing is that you're still shopping. You're still shopping for topics. And what you can do for me, which I asked you to do yesterday, still send me, after this discussion now, send me 3 topics that you are thinking about doing, do their literature review and see the feasibility of doing the topics. At the end of the day, we might be able to choose one for National College, one for West African College, and maybe discard the least probable one. But you need to do that by yourself. Don't go into neuro if you are in a center that is not doing neurological cases very well and you don't have a very good neurosurgeon, because you will spend 1 year and you have not gotten enough sample size. I have passion for obstetric anesthesia and I'm an obstetric anesthetist, and obstetrics can never fail you. If you do have obstetric patients, go to the labor room and look at the obstetric patients and see the problems they are going through and see what you can do for them. You may be more likely to get a reasonable topic that is smart. What do we mean by smart? That the objectives are smart, that you can easily, is achievable, is measurable, is reproducible, is time bound, and is specific. That's the meaning of smart. So another area that is very good to do is airway management. Another area that people find okay is pediatric anesthesia. Although pediatric is, well, you need to be interested in pediatrics to be able to do it. But those 3 areas, you cannot fail. Then you can also do regional. You can do regional blocks. You can compare different blocks for post-operative pain management and see how they fare, the outcome for a particular type of surgery. Okay, so those are the clues I can give to you, the tips I can give it to you. Write it down now. Check obstetric, check regional, check pediatric, check airway management, and see. Then go to the college, the different colleges, the 2 colleges, they usually give lists of proposal topics and dissertation topics that have been done in the last 1 year, 2 years, 3 years, 4, 5 years. Don't go beyond 5 years, okay? See if it's something that you can do. Can you hear me?
Yes, Prof. Byron.
So I think we have dispensed with your topic. Write down the clues I've given you, develop it. You can communicate with me privately. I can take you through that. Okay?
Thank you very much, ma'am.
You're welcome. Dr.
Actually help us.
Thank you very much, ma'am.
Really
You're welcome.
help us to hit the ground running. In fact, I don't think we are really running. We are already flying because we are discussing part 2. And I can see that the participation here, we have participants that are over 105 participants here. So, and scanning through the attendance, I realized that we have people who are about to do even primary, those who are going for part 1, those who have just passed part 1, and those who prepare the candidates for both parts, part 1 and part 2. I can see Dr. Wale Adebiyi here, Dr. Resonwo is here, Dr. Lukman Lawal is here. So, and then if we look at the structure of our examination, we realize that even some of the things that are being done now are evolving. So this is an opportunity for us to actually ask questions so that we can be very clear about the methodology of these exams and also what it requires for one to pass. It's not just a display of knowledge. So we need to know the technicalities. The multiple choice questions is the best option. So how do you go about this? I would expect some of us to ask the questions concerning that. Then for national, we do short answer questions. So you need to really know how to write, what to write. This is the time for you to ask, because sometimes people just write 7 pages for one SAS, and you have 15 questions to do or 10, and you only have time to write for 5 questions. And of course, you know the result of such exam. This is the time for you to actually ask questions. Then concerning OSCE, I think OSCE is a challenge for both the candidates and the examiners. So it's an opportunity now to actually ask questions. Then orals, although oral is a long-standing traditional method of examination. Although in no particular order, I will also ask questions, not necessarily from primary to DA to part 1 and to part 2. And for those who have just even passed the exam, there are challenges. You will raise it up now so that we can really shine the light in the tunnel for those who are coming behind us. So we expect more questions to flow in. Thank you very much.
Thank you, Dr. Lawal. Thank you for anchoring that. So I saw in the chat, I saw some questions in the chat. Before we take the questions in the chat, I have an interaction with Dr. Stanley Igwe from UNTH Enugu. I asked him to join the meeting on time, and I saw that he's already logged in. Dr. Stanley, are you with us? Hello, Dr. Stanley, are you with us?
Yes, Prof, I'm here.
Good evening, Dr. Stanley. You're welcome to this session. I'm going to read out your questions, and then I'm going to try and answer the questions the best way that I can. And then I will now give you suggestions going forward, how to tackle those kind of questions. So please, and others, if others have suggestions, Dr. Lawal is an examiner in West Africa. If you have suggestions on other ways to tackle these questions, please just give us insight. So the question goes like this. I observe some of the management questions have no clear-cut answer. Depends on what a particular examiner wants to hear. Some of these kind of questions include: 1, your resident or consultant came to work drunk. How will you handle this situation as the head of department? 2, your resident or your resident fought with a nurse anesthetist. How will you resolve the matter? 3, you have a resident that always comes late to work. How will you handle it? 4, your department lost accreditation. How will you tackle it? 5, you are about starting a case and your resident informed you the patient in another theater suite just had cardiac arrest. How will you manage the question? Thank you. So I will take the questions one by one. It is not true. First of all, your assertion that there is no clear-cut answer is not really true. What you need to know is that everything has a manner of approach. So you need to have an approach to these questions. These are called management or clinical governance questions. And they are very important, especially as you get more senior in the specialty and you become a decision maker. As a consultant, you are a management staff already in the hospital, and you should be able to solve these questions. Unfortunately, there's nowhere in the syllabus that we are taught how to do these things, but you can check them up in business administration, business management topics, and also encourage doctors to do courses in business administration or in management or in public health, anesthetists especially, because anesthesia is a bit abstract and then you need skills that are not really clearly taught. But when you go to all these other domains, you find that there's quite a lot to do. So coming to your first question, your resident or consultant came to work drunk. How will you handle this situation? Okay, so this question, and generally all these questions, when you are asked all these questions, you need to first introduce the topic. You need to understand the background of the topic. You need to understand the background of the topic and know that, first of all, this question is talking about alcoholism or ingestion of alcohol at a wrong hour. And this is a sign of indiscipline and poor work ethics. But before you go talking like that, you first introduce the topic and say that this person is possibly having some difficulties, that you will need to find out what the difficulty is. So you introduce the topic by saying that alcohol ingestion in the morning or being drunk in the morning is not an acceptable behavior. So you will first of all find out, has this been the practice or is a one-off event? So you need to find out, has this person been taking alcohol before, or it just happened by mistake, or he attended a party and got drunk? So first and foremost, you need to get the background of the doctor. Is he a known alcoholic or a known person that takes alcoholic drinks, or is just a one-off event? Secondly, you need to get the doctor to a quiet environment, a quiet place, maybe your office or a consulting room or somewhere secluded where you can have an interaction with him as the head of department. You may not need to start raising alarm and say, which kind of doctor is this? Or start blaming him or start castigating the person in public. No, that is not a good approach. This is an approach that needs maturity. Then you need to get maybe a doctor who is probably a psychiatrist or psychologist or something to refer the case to after the initial interaction with the doctor. So you need to find out the background. Is he having family problem? Is he did he attend a party and get drunk, and or did he is he responding to some family pressures or problems, or it could be anything. Okay, so you keep an open mind, you're not judgmental, you hear the person out. If he's willing to talk, you listen without making any judgment. The best thing is not to say, I will punish you. I will write you a query. How can you come late to work and all that and all that? No. So in answering this question, you need to state that it's a case that may need further investigation by colleagues who are specialists in that area to understand the medical problems or the other problems associated with it. And you need to treat the colleague with compassion and with empathy to understand the problem, not to be judgmental. And then going forward, you need to set ground rules, because it may not be the only offender. There may be other offenders, or the future, it may come up again in the department. So the department, you need to set ground rules, and you need to intimate the staff with the working conditions or the job description and what they are expected to do, standard operating guidelines. If the hospital has it, fine. If the hospital does not have it, then you will need to develop it. And that is in brief what I can tell you about that question. Let's move on. So I hope you got what I'm saying. Hello, Dr. Stanley.
Thank you very much, ma'am.
Yeah. Okay, so can I move on?
Yes, sir.
Yes, ma'am. Thank you so much.
Okay, the second question is, your resident fought with a nurse anesthetist. How will you resolve the problem? This question, they can say had an altercation. They may not say fought with, or they may say slapped, or had a misunderstanding. Okay, so this question is about conflict resolution. So conflict resolution is a special skill. So you introduce the topic. You first of all say what it is about, and you introduce the topic and say that it can be challenging to resolve. And you need to say that conflict, wherever human beings of different walks of life and different backgrounds are together, conflicts are bound to happen. But it is how they are solved that makes the difference. So as a head of department, you should be well-versed or in the art of conflict resolution. If you are not very good at it, you can invite somebody to assist you. That's what you should say when you are answering this question. Then you should say that first and foremost, you need to listen to both parties differently or at different times. It is not ideal to call the doctor, call the nurse and say, okay, you are friends now, hug each other or shake hands and say sorry. No, you cannot force people to resolve a conflict. First, you must understand what is causing the conflict. A lot of times it may be work related, it may be personal, it may be, maybe they may be having some other issues unrelated to the work. Maybe the man may be making an approach, an amorous approach to the lady. Maybe the lady is not interested and things like that. So don't just quickly say, oh, no, you people cannot be fighting now. Your brothers and sisters, okay, shake hands and go. No. Then you have to be conscious of the religious background and the socio-economic background of the parties involved and the cultural setting. In some cultural settings, it's not acceptable for a man to just bring hand and say, okay, shake my hand. We're friends, no problem. No, it's not, you don't do that. So first of all, you listen to both parties individually, then you find out what really is causing the conflict, and then you try and see. For the nurse anesthetist, she's not working directly under you. You may need to ask the head nurse anesthetist to talk to the nurse anesthetist to intervene in the matter or to listen to the situation and then give you a report back. For the doctor, yes, doctor is with you. So you may need to say, okay, let me listen to you. And when you listen to the person, Don't take sides. Don't say, "Ah, it's my colleague, now I have to protect him." No. If you have seen clearly that the doctor has overstepped bounds, please, in a nice, calm and gentle way, point it out and say, "Oh, no, you shouldn't have done it this way. Please, next time, do it like this." Don't say, "I say, doctor, I have to cover him up." No, no, because you are dealing with adults. Even children, when they are right and you're trying to deceive them to convince them that they are wrong, they will protest. So, and then another thing I need to say about conflict resolution is that you don't have to escalate it. Some people will say, okay, I'll give you a query. Why did you fight with a nurse? And then it brings in more bad blood, more animosity, and all that, and all that. So find an easy way to resolve the problem and get feedback after that day. Subsequently, make sure that they are reconciled. You can say, whoever is sorry, is able to say, "I apologize," or "I'm sorry." Some people are not able to even apologize. You don't have to force them, but they should still understand where they went wrong. And then you make a follow-up, or you do what they call debriefing. You can, after a day or 2 days, do a debriefing with other members of the department or members of the team and say, "Okay, this is what happened yesterday. So how are things now?" And everybody will say, "Oh, this is fine," or "this is not fine," or "this is still lingering on." And that is it. It's simple, but it can also be very delicate. It's a delicate issue, and you need maturity, you need tact to handle it. So make these notes down and write it down. You may not say it exactly the way I'm saying it, but follow it systematically, okay? Then the third question, you have a resident that always comes late to work. How will you handle it? It's similar to the first two. Find out the cause of the problem. Why is he always late? Some people will drop their children in school before coming to work, and by so doing, they'll be late. Some people, they don't have a good car, or they don't even have a car at all. By the time the person giving them a lift to work comes, it's late. For some people, it may just be a bad habit. So you need to find out the cause of the problem and try to solve the cause of the problem. Not that you will buy a car for the resident that doesn't have a car, but you can say, okay, if you need to be at work by 8, leave your home at 7 a.m. to give you some time to get to work. Maybe traveling to work takes 20 minutes, give or take, hold ups and hello, please, if you're not speaking, can you mute yourself? Who is the host of this meeting? Okay, I'm the host. Okay, I will mute Agedo Matthew. Agedo Matthew, please, you're disturbing us. I've muted you. Okay. Please, others that are not speaking, please mute yourselves. Okay, so back to the question. I hope it is clear. So you need a background. You need to find out the cause of the problem. You need to approach it systematically, methodically, and in a mature fashion. And most of these issues can be handled in this way. And then after that, you need to have a feedback or a debriefing session a day or two or a week later, whatever, to follow up to know how it is. Are you with me, Dr. Stanley?
Yes, ma'am.
Are you making notes?
Yes, ma'am.
Okay, so the fourth question, your department has lost accreditation. How will you go about it? Okay, department losing accreditation, that is a management issue. And what they expect you to do is to, first of all, discuss with your hospital management. Usually is the CMAC or Director of Clinical Training that is in charge of all those things and who will report to the CMD. So we bring it to their notice. So you will need to approach the college that you have lost accreditation and you will need to be visited. So you need to know who which college is it? Is it National College? Is it West Africa? Is it both? You need to approach them. You need to call the faculty chairman and say, okay, this is the issue. Please, we need to renew our accreditation. Then usually they will give you the guidelines for the accreditation, the requirements. The institution will write to the college. The college will respond by asking the institution to pay the accreditation fees. Then they will give the date, proposed date of visit, which if it is acceptable by all parties, then they will now fix the visit. They will pick an accreditation team, usually the chairman of the faculty secretary, and a third member. And in the absence of them, there are usually people that will be delegated to act in their place. So that is it about accreditation. So you prepare for the visit, you get the list of requirements, you get the things you're doing in the department, your training, your seminars that you're doing, the cases you're doing in the theater. You must have your logbook of cases for the residents and all that. So the requirements are given by the colleges. You try to meet up the requirement. And when the time for the visit comes, you'll be there to receive the panelists and all that. Of course, you have to be a good host and provide accommodation, feeding, and transportation and all that for the duration of the accreditation visit. So that is that about accreditation. It's a straightforward thing. Then 5, you're about to start a case. Your resident informed you a patient just had in another theater suite, just had cardiac arrest. Dr. Stanley, this is straightforward now. You're about to start a case. You have to leave the case because once the cardiac arrest has been announced, it's code blue. Code blue means that everybody leaves everything that they are doing and goes to the site of the event to rescue, okay? And you start the process of CPR. So what they want you to say in this case is that this is a challenging situation, it's a dilemma, but since you've not started your case, you will stop whatever you're doing, leave the patient maybe with the nurse anesthetist or the anesthesia technician, and go to the unit, to the suite where the patient has had a cardiac arrest and initiate CPR. Of course, don't just stop at that. You need to discuss the process of CPR, CAB, circulation, airway, breathing. That is the protocol now. But you can still say airway, breathing, circulation. Nobody will penalize you. So you need to know basic life support. And if it is so serious, you may need to do advanced cardiac life support. So because of time, we will not go into details with that. Maybe what I will do in the next series is that we can take this question as one of the questions for a seminar, management of cardiac arrest in the perioperative period. Maybe I will ask Dr. Briggs to incorporate it into our sessions. Okay. I hope I have answered your question. We need to move. I've spent almost 15 minutes on this, your question, Dr.
Thank you very much, ma'am. You've done exactly that. And yes. I think we need to move on because it's very important that we cover areas that are meant for people going for diploma, those going for part 1, and then those who are going for the part 2. I think we've done something on part 2. There's a
doing part 2 now.
Dr. Ogundeji, but okay. I think we may come back to that. Another question is from Dr. Aminu, and the question reads, please, how long does it take to get approval for WACS exemption. That is still part of part 2. So I think we will help us take that, Prof. Also,
Okay.
I crave your indulgence, Prof, that
Yeah.
I announced the presence of Dr. Abiola Mafe,
Okay.
an examiner with National Postgraduate Medical College and a resource person for Lagos State Health Service Commission. Also, I can identify Dr. Naji if it's the Naji I have in mind. He also can be a resource person on this. You are all welcome, Dr. Naji, Dr. Abiola Mafe. You are welcome.
Thank you, Dr. Lawal.
Thank you, Dr. Mafe.
Onwaso.
Thank you for being here,
ma'am.
Dr. Mafe. We will need your wealth of experience in national issues because you are a faculty board member. And so we're going to call you in due course to give us some information. Thank you very much for joining the seminar today, the webinar today.
Thank you.
So,
thank you, ma'am.
You're welcome.
Can you please take the WACS exemption question? Thank you, ma'am.
Okay, thank you very much for that question. Well, there are stages of exemption. Exemption can be towards part 1, it can be towards primary. Usually, if you have primary of national and you are applying for exemption for for the primaries for West Africa, you can use, you apply, you will be asked to pay, and once you pay, you will, it goes back to the college. I know people that have gotten their exemption within 6 weeks to 3 months. It all depends on a lot of things, logistics, where you are located, and maybe follow up. Sometimes when you apply to the college, you may need to follow up, because these are administrators that are into other things. They may not quite they may have a lot of candidates that they are handling, and they may not have also a lot of time to attend to one person alone. So it's important that you also do the follow-up after applying. So I think the 2 or 3 of my residents that I had to intervene in their case, it took about 3 months. But on a good day, 6 weeks to 2 months is just enough time. It's just enough time to get exemption. But you start early. Start early. If you intend to do the exam in April next year, start to apply for your exemption now. Because if you're applying for exemption now, you cannot meet up for October exams. But if you apply for exemption from this, let's say August or September, latest by December, you should be able to get your exemption so that you can apply for the next exam in April or May, depending on the college. So that is that question. I hope I have done justice to it.
Thank you very much, ma.
Thank you.
From my end there, I think you've done very well. I don't know for the candidates. But I think in the same vein, ma, we can quickly take Dr. Nwigwe's question. It's
Okay.
very similar to the question for WACS, but it's from the National Postgraduate Medical College. It reads that how long does it take to get approval from National Postgraduate Medical College? What measures can one take to hasten the process? Thank you, ma'am.
Okay, thank you very much. I think this is a national question, and we are privileged to have Dr. Mafe, that is a faculty board member of National Postgraduate Medical College. Dr. Mafe, please, can you throw more light on this question? It says, how long does it take to get approval? I think this is approval for a proposal, I think. It must be from National Postgraduate Medical College of Nigeria. And then what measures can one take to hasten the process? Yes, he has added it. Dr. Mwigwe has added approval for proposal. Dr. Mafe, could you do us the honor? Thank you, ma.
I must say that now the projects are uploaded, and usually it's minimum of about a month to 3 months, 4 weeks to 3 months. The thing is, if, however, you know, the examiner is not doing it early enough, the registrar of the college kind of prompts you. Like if you've not checked your mail, for example, you've not checked your college email for a while, maybe you've just not checked, you get prompted from the college to tell you that there is a proposal in your box. They appreciate that you are very busy and all of that. Please ensure that you read it. So that for national, I can vouch that if you are not, you know, if you don't get your response on time, I know that the college keeps checking the examiner's mails to see whether you have attended to that proposal or not. And immediately you've attended to the proposal, you get prompted again that, and usually, you know, there's something in it. So there's a way that you yourself, you would want to do it. So let's say, give or take a month to 3 months maximum, you get your response.
Thank you very much, ma. Yes, ma. Thank you very much, Dr. Mafe. We really appreciate that. So, Dr. Mwigwe, I hope that satisfies you. 4 weeks to 3 months, it's a good time. So, how can you facilitate it? He was asking that how can one facilitate it?
Well, to facilitate it, really, you don't need the facilitation. I must say here that it's a bit different from the West Africa, because recently, practically, I know somebody, one of, you know, students that have been waiting, it's now going to like 5 months since she submitted the proposal. And I know that they have to be contacting the faculty chairman of West Africa, and he says that is some of the problems they have. In national, you get prompted, the examiner gets prompted by the college that, you know, in a nice way too. They say, they call you, they will call you on your phone. Please check your mail. There's somebody that has submitted. It seems like you've not checked your mail in a while. How soon can you get it ready? Since it's been a while, and then they give you, you know, that time again, that please, if you can do it so that this person can have their book early enough. And then, of course, you yourself, knowing that, you know, you've kept that person waiting, you would want to do it as early as possible. So usually the college does the prompting, I must say. The registrar will prompt you, and if the registrar directly doesn't prompt you, the people in the office will prompt you. Either they give you a call, or that is the examiner, not the student. They will call the examiner, remind you that you have a mail, there's a proposal waiting, there's a part 2 project in your box. Kindly ensure that you do it as soon as possible so that it still falls within that allotted time.
Thank you so much, ma. Thank you, ma. I think we have done justice to that question. So you don't need to take any special measures, Dr. Mwigwe. The college does everything for you for national. Okay. Thank you. Back to you, Dr. Lawal.
Thank you very much. I think we can now move on to this part 1 related question from Dr. Ogundeji. I know Dr. Ogundeji very well, and I know that he's answering this question for the benefit of the candidates. I will also want to tell the candidates on board to please ask questions. There is no bad question, please. From asking question about multiple questions or short answered questions up to OSCE, orals, things that you exam. For those of those past exam, the challenges you face, you can also bring it up as questions or comments so that we can shed light on these things now. So don't let us waste this opportunity we have. So what Dr. Gundeji is saying here is that what is the format or outline for answering anesthetic management questions? What I can say is pre-operative, intra, and post. But my job today is to moderate, not to answer questions. Prof, can you please help us take man?
As a moderator, you can still answer now, Dr. Dr. Lawal. You can throw some light on it. Hello, Dr. Lawal.
Yes, okay. Prof, let's maybe since we are here, can you please help us with this question?
Okay, no problem. You're welcome. So it says, please, sir, kindly give residents a format or outline on answering anesthetic management questions during theory exams. Okay, so in the management, that is like saying what is discuss or describe the anesthetic management of a 50-year-old woman who has been having amenorrhea for total abdominal hysterectomy. I just thought up of the question just now. It's not a question, but in that kind of question, you need to start with an introduction. In your introduction, you should say a 50-year-old woman. So the keywords, you bring out the keywords, and the type of surgery is a gynecological surgery, total abdominal hysterectomy. What are the important considerations for this gynecological procedure? So that is what we form the introduction. Some people will just say anesthesia for a 50-year-old with a poses a challenge with the anesthetist. How? How? Don't just say it poses a challenge. Mention what are the areas of challenge for this that particular type of surgery. For instance, if it's a pediatric case, you should say maybe if it's a neonate, you should say because the organs are not well developed, because there's anatomical differences, because of large head, relatively in relation to the body, difficulty in intubation. You know, just quickly, succinctly in the introduction, you can enumerate the challenges. Then, I mean, you can just quickly in a sentence say the challenges with this, and this. Then you go to anesthetic considerations. In anesthetic considerations, what is important to you as an anesthetist in the management of that patient? What are you thinking about? For instance, if you have a geriatric patient, a geriatric is elderly, let's say 70s or 80s. What is really the thing worrying you? In the geriatric patient, you're worried about difficult airway because they may be a dental loss, they may have a stiff neck, inability to open the mouth, you may have difficulty in setting a line and all that. So you mention those things in your anesthetic considerations. Then you now start discussing your anesthetic management with a view to outline how to take care of those considerations you have elicited or you have enumerated. So you now start from pre-op. Pre-op, what are the things you do in the pre-anesthetic visit that are important that will help you to manage the problems of this group of patients? Intra-op, what do you need to do for a geriatric patient? What do you need to do? You need to know that the person can be susceptible to changes in temperature, especially just like a child. It can develop hypothermia. You should not be exposed too much. You need to know that the fluid management too, you have to be careful with it. You don't overload the heart and all that. So when you're doing your pre-op, intra-op, and post-op, you must bring out those important things. It's not one size fits all. It's not the same thing you write for obstetric. You come and say, yes, you know, because in the obstetric patient, a supine hypotensive syndrome. Then a non-obstetric patient, you mention supine hypotensive syndrome again. No, you must be specific. You must know your subject matter very well, and you must have a good command of whatever that question is asking from you. For instance, if you're talking about a neonate that is going to have surgery for a pyloric stenosis or something, you will not start discussing the management of an 8-year-old. This is a neonate. So the things that are important in neonatal physiology, those are the things that you will highlight and bring up. So I think I've talked enough about this, but basically have a pattern, introduce it, have an outline, then do your introduction or background, anesthetic considerations, then pre-op, intra-op and post-op management of the patient, and then conclude. Always try to conclude. Don't leave your patient midway. If you have intubated the patient, no matter how much that you don't have time, extubate your patient. Recover your patient. Send your patient to the recovery room. Don't say, hey, I didn't have time to finish. How? So that is where time management also is important. Okay. I hope I have thrown some light onto that question.
Thank you very much, ma.
You're welcome.
You've done very well in taking us through that outline. And Dr. Ayode is leading us into the next phase of the patient management. And she's opening the gate for post-op reversal and extubation and post-operative management. Our question is question one. What airway, respiratory, and cardiovascular problems may follow the removal of a tracheal tube? List the factors that may contribute to a high-risk extubation. Outline the strategies used to prevent airway complication if a difficult extubation is anticipated in the operating theater. Thank you very much, ma, for obliging us again.
Okay, thank you, Dr. Ayode, for your question. The first says, what airway, respiratory, and cardiovascular problems may follow the removal of a tracheal tube? Okay, so this question is just simply talking about complications of endotracheal intubation, more or less. So you need to take it systematically again. You need to talk about the problems related to the patient, the problems related to the equipment, and the problems related to the technique that you want to use for the removal of the tube. Are you doing an awake extubation? Are you doing a deep extubation? Are you extubating midway or in between planes of anesthesia? So this question, I'm not going to go into details and say these are the airway problems and just answer it for us. What you just need is an outline, introduction to the subject matter, and mentioning what is endotracheal intubation, and in a sentence or two, how it is done, and then the different methods of removal of endotracheal tube. And when you do that, then you can now start talking about the complications of extubation. And then that is when you will now talk about the airway complications, respiratory complications, cardiovascular problems. And if you approach it in that way, you'll be home and dry. The next question, list the factors that may contribute to a high-risk extubation. Okay, The person asking this question, I don't know what you mean by high risk extubation. Is Dr. Ayoade on this call? Dr. Ayoade, are you on this call? Hello, is Dr. Ayoade on this call? What do you mean by high risk extubation? Yes, we want to listen to you. What do you mean by high risk extubation? Okay, you're finding it difficult to unmute. I can unmute you. But you can unmute yourself.
Okay, good evening, ma.
Good evening.
Good evening, ma.
Yes, good evening.
Yes, ma.
Go ahead.
Actually,
yeah.
Okay, it was an essay question, ma.
Okay.
So I didn't actually understand it, but it was a question in one of the DA. I'm actually planning to write diploma in anesthesia. So
Okay.
it's one of the past question, theory past question, ma.
Okay. Well, maybe what they mean is that the extubation is going to be difficult, or the patient is going to develop complications after extubation, and so you need to manage the extubation, the stage of extubation. But for me, this question is a bit bogus. It's a bit very fluid or ambiguous. It's difficult to say what you really mean, what the examiner means from this question. I don't know if Dr. Lawal or Dr. Mafe, Dr. Naji, can you lend us a helping hand?
Dr. Naji, are you there? Okay, Dr. Ayoade,
Prof, can we have the question again? Sorry, I was on a journey, so I lost contact with the Zoom and just came back in. Sorry to drag us back.
Okay. No problem. The question is, list the factors that may contribute to a high risk extubation. Dr. Mafe? Yes, high risk extubation. The Dr. Ayoade is the one that contributed the question. She said it's a diploma in anesthesia question. And she's preparing for diploma, so she wants to know.
It's a three-part question anyway.
Yes, three parts.
Is, the factors that may contribute to high risk extubation. And then three, to outline the strategies that can be used for difficult extubation.
For me, like you said, it's for DA, I think it's rather ambiguous for DA. If it was for part 1 or part 2, yes, because really what we don't expect that much from DAs, just ensure that they are safe. You understand what I mean?
Yes.
But I guess before you extubate, they probably want the patient to be fully conscious, airway fully, airway reflexes fully intact, patient able to lift their heads for a few seconds. You know, you're sure that you have recovered them from the effect of neuromuscular blockade, and all those tests that we say, lift their heads, be able to have a good arm grip, you know, and all of that. And if you are using a neuromuscular blocker, I mean, what is it called? What is it called now? Neuromuscular assessment thing. A peripheral nerve stimulator. If you are using a peripheral nerve stimulator, for example, then of course if you had used a long-acting muscle relaxant. You want them to be able to fulfill the criteria for their 3 or 4, train of 4, and all of that. That's my point. So I think those are some of the things they're looking for to be able to fulfill those criteria before you now extubate safely.
Thank you very much,
Dr. Nagy. And
Dr.
as
Matbe,
I would like to add that you gave us a clear description of awake extubation. Sometimes we may need to extubate the patient deep and also ensure that we have a good postoperative monitoring system in the recovery room. That's one of the strategies to prevent complications and ensure that should there be need to reintubate, we will be able to do so in the postoperative period. But good monitoring in the immediate post-op after deep extubation is very, very essential. Sometimes we may not even, as a matter of strategy, you may not even need to extubate the patient if the condition is such that the patient will not be able to support his or her respiration. So in that case, we may need to refer the patient for elective ventilation in the intensive care. That's one or two things I can contribute. Thank you very much. So we now, and
thank you, Dr. Lawal. Let's go on, because the last question you have already given the solution, that is to the post-operative part.
Yes,
the third part of the question, you have already answered it. So let's move on. There's a challenging question by Dr. Belema. Maybe you can read it out.
Thank you, ma. Thank you, sir.
Belema Oduma.
Yes.
Okay. From the National Part 1, the question says, we notice most. Okay, this is about single best option. So she said sometimes the conditions are confusing. And so I think this question is beyond me. I will refer this to the prof, because sometimes the intention of the examiners, especially the professorial ones, is to confuse the candidates. So why do you do this, ma'am? Thank you.
Actually, I don't think it is to confuse the candidate. They say single best. Now, you will have good, better, best. So in the answers, you may have, like you said, a stem, 5. There are 5 answers in the stem, and 3 or 4 are correct, and only 1 is totally wrong. And they want the single best option. That means there's one that is a good option, there's one that is a better option, but they want you to choose the best option. So it requires a relatively higher knowledge of the subject matter. And maybe if something is stated in percentages, it may require that the one that is having the highest percentage of incidence for that question being asked is the one that will be the single best option. So I want to apologize on behalf of the examiners that if a question looks ambiguous, you may tend to be confused. I agree with you. But all the same, there are sometimes some questions are tricky. They introduce a twist or a trick into it. So you need to really, be sure about it before you answer it. So it eliminates guesswork. Because if you don't know exactly of a certainty that this is the correct answer, if you guess and you select the other one, it will be wrong, and then you will lose marks. So that is the trick in those kind of questions. So what I do is to eliminate, do the law of elimination. This one is correct, but this one is more correct. I choose the one that is more correct. Out of the one that is more correct, there's another one that is most correct. I now zero on the one that is most correct, and that will be my final answer. So that's how it is. It's just like if you have been there watching Who Wants to Be a Millionaire, they will just put all the options very close together. So you just have to know it to be able to get the right thing. Because if you guess, it will be the wrong answer. So I'm sorry about that, but that is one of the ways the examiners are thinking, that they want to, get a good grasp of the knowledge that the candidates have about the subject matter, that the candidate has precise, detailed knowledge, not guesswork. So I think it's usually commoner in part one.
I think this is Jamin, because the MCQ now is being used to weed candidates. So it's better one has a good depth of knowledge of the subject matter, and also to understand the principle of answering the question. The whole 5 options may be correct, but one is most correct. Also, there's one that is the best option. And I know that our resource person in the house now, she loves playing around with these type of questions. Maybe she can also, without letting anything out of the bag, maybe she can also help us shed some light on this. Dr. Mafe, please. Hello?
Hello, Dr. Lawal.
Are you there, ma?
I'm so sorry.
I know you know how to catch. You know how to.
I just came in now and
this ambush.
A phone call just came in, so I was one ear into Zoom. What was the question?
Okay.
Sorry.
The question was that what some of the candidates find the single best option questions confusing, and the prof has actually helped us to shed some light on it, that it is not a matter of trying to confuse them, but to ensure that you have the sufficient knowledge to pick best. And I know that this is one of your examination interests. So can you help or help the candidates on how to approach the single best option MCQ? Because this there's a paper that is used to weed candidates. So if they understand what it is, they find it less confusing and they can do better.
Thank you, Dr. Lawal.
Yeah.
For us, there's something that we do in my center. If you go for an exam and you come back and it's that weeding exam that you fail, then we tell you that your reading is not sharp enough, if I can put it that way. Because when you read generally, it's easier when you read just like a newspaper, you may not really get the nitty-gritty of what the whole paper is talking about. But if I said to you, we're reading paragraph 1, and I'm going to ask you a question on paragraph 1, you will find out that you are looking more for details. And that is exactly how you read for best option, honestly. Because one of our candidates who went for the exams, I think she had done it for like 2 times. And we just told her that, look, this thing is about looking for what others are not looking for. You've read this thing now. So 3 of us, we decide that, okay, we are reading first chapter in Aitken Head, for example. And I tell you that this is what we're going. And you find out that when I'm now asking, what is this? What is this? The figures, if it's in pharmacology, for example, you will read propofol and you will just read it as propofol, the IV intravenous agent, milky substance. I'm looking for the percentage of soybean in that propofol. I'm looking for the percentage of glycerol, percentage of water, because those are the things I know you are going to overlook. So it's the nitty-gritties that, and when you get to say physics. You can't just read it and pass by. You must know those equations. Yes. So I think best option brings out the best of what you have read of the context, rather than just reading generally. When it was true or false, you could walk it through, because once one is false, the others are true. And so it was more of a game of chances. But now it's about your knowledge of the topic. Thank you.
Thank you very much, ma'am. I know you will do justice to that. Thank you very much. I think we are better off now. I think we've not touched on short answer questions and also OSCE. Let's have questions that will lead us into this. The short answer questions, because this is another area where candidates don't really do well.
That's about it. What I do for night.
Ogun
Gregory.
Hello?
Ogun Gregory, we have muted him.
Okay.
Okay, let me mute him.
Hello? So we want questions that will really lead us into essay writing. We've done well with patient management, but short answer questions, SAQs, and also OSCE, then we can talk of orals. So if you have experience, you can even get feedbacks from those who have just gone through the examination. So tell us what things you think we need to look at concerning the examination. And for those who are preparing for the examination, what are the things you think you need to know that will help you in your preparation? Dr. Olesongo, you are there. You should be able to say something. Dr. Lawal, Dr. Ladapo, you can give us your experience. So we want questions to come in. Thank you very much.
Thank you very much, Dr. Lawal. Dr. Mafe has thrown more light by saying that in single best answer, there's no negative marking.
Yeah.
But it's in true or false that they have negative marking.
Okay.
So in single best answer, once you know the best answer, one is one. There's no penalty again.
Okay.
Because there's a question from Dr. Ken Irole that says, thank you for this opportunity, ma. Sir, please, is there negative marking in the MCQ? If so, what is the range of the negative marking used?
Okay.
So in SBS, there's no negative marking. It used to be, I think, 1/4 in true or false, but I'm not sure. I cannot say categorically. But both colleges are using single best answer. So don't prepare for true or false. One of my residents, very brilliant lady, she went to the exam with true or false in her brain. And the exam was single best answer. And she answered it true or false. She answered it as true or false. Of course, she didn't pass. So please, when you are going to the exam, read the instructions before you start. Read it again before you start. Read it for the third time and make sure you understand the instructions. And also listen to the examiners, the invigilators. They may have a word or two to direct you or to tell you on what to do. So that's it about that. So you wanted us to discuss about the short answer questions. The SAQs is just answer it by keys. What do I mean by keys? Keep it short and simple. Short answer questions should be just like a lady's gown. Long enough to cover every important details, but short enough to make her look beautiful and nice. So you don't answer short answer questions like long essays or the classical theory question. So the short answer questions, especially for national, maybe we'll call on Dr. Oresonwo or Dr. Mafe to talk about it. But the short answer questions, what I know is that if you're asked to talk about cardiac output, for example, go straight to the point. Just talk about cardiac output. Don't start fishing around for other things to say. Don't start fishing around for other things to say. Go straight to the point, define cardiac output, define the factors that affect cardiac output, say how to measure cardiac output, say the problems you have when there is a difficulty with cardiac output, or the pathologies that arise with too much or too little cardiac output. Conclude and go home, that's all. Don't go to town and start saying too many things. Again, you don't have time. If you go to town, time may not be enough for you to finish. And if you don't finish, you may lose marks, because it's important that you answer every question. So that's it. So Dr. Zango has made a contribution in the chat by saying that the CBT candidate cannot even answer true or false because the computer will not allow that. Yes, now this one happened about 4 or 5 years ago, before they started using these JAM CBT centers. The case of the person answering as true or false instead of single best answer was some years ago anyway. So Dr. Zango is saying that if you are using the CBT centers, the CBT candidate, you cannot even answer true or false. You have to the computer will not allow you to answer many options, just one option. Okay, I hope that is clear about
Thank
short
you very
answer
much,
questions.
I
The
want
other
to
one
thank
you wanted us to talk
Dr.
about.
Zango for taking us to CBT, because talking of CBT we lead us to time management in examination, because the computer will not allow you extra time. And once your allotted time is spent, the computer will blank you out. So maybe we can benefit from your experience, ma'am, by telling us generally, you mentioned it during the short answer question, that you need to go short and simple and make a conclusion. In the patient management question too, you told us introduction and conclusion are very important. So generally, and also I know that with OSCE too, because we've not touched on OSCE at all, but I think with OSCE too, it's a matter of time. You need to move on to the next station, and you don't have the opportunity of coming back to that station again. Unlike when you write your essay, you may do number 4 first and go back to number 1. So can you please help us with your own experience on how best candidates can manage their time during the examination? Thank you, ma'am.
Okay, thank you very much, Dr. Lawal. Before I answer that, there's a comment or a question from Dr. Gregory Ogun. He says, if the question is list, is it to just list or introduce the subject matter before listing? Well, if it is a single best answer and you don't have time, if it says list, if it's a short answer question and you don't have time, if you say list, just list. But you will not get marks for an introduction, but I always like people to have a short one sentence introduction. It may not earn you marks, but it will just show that you are a superior candidate to the person that just goes straight to list. So if you've mastered your time and you know that you can in 5 minutes say what an introduction to what you want to say, Let's say, for example, they say list the complications of endotracheal intubation. You can say endotracheal intubation is a passing of a tube into the specially designed tube into the trachea. It doesn't take you anything. It's complications, 1, 2, 3, 4, and you list the complication. You can even classify it early and late and things like that. So when you do a brief introduction, it says that you are a superior candidate. You are more detailed. You are more meticulous, you pay attention to details and all that. That's it. There's another question in the chat. Before I go to what Dr. Lawal asked about time management. Thank you, Maz and Saz, for your guide. Please, I want to know if there are difficulty in submitting the CBT at the end of the questions. What should be done to ensure that the questions are submitted? Thank you. This is from Dr. Tajuddin. Now, from what I know, if you have any problems, technicalities with your computer or anything, it's best to draw the attention of the examiners and the invigilators to the problem you're having. Don't just stay in silence and think you can solve it and that is it. Okay? So if you have a challenge, you may need to contact the invigilators. They may have a solution. Sometimes it can be so bad you may need to be given another computer to work with and all that. I hope I've answered your question. The next question is, the short answer question is only practice in national exam. It has 2 parts, principle and practice plus ICU, comprising 10 questions, and allied practice containing 8 questions. Thank you very much, Dr. Shuaibu Ibrahim, for that. Yes, you have given us the structure of the short answer question. Thank you very much for that. We appreciate that. So I hope our listeners have heard that the short answer question is mostly for national, and it has in principle and practice and ICU, it has 10 questions, and in the allied practice, allied specialties, it has 8 questions. So, Dr.
We are fortunate to have Dr. Shaib on the
call.
List, yeah.
Yes, yes.
So you are welcome. You are welcome, sir. And thank you for the contribution.
Yes.
Can you please help us take this next question with the permission of President? It has to do with the instruction to the candidates. Candidates get muddled up sometimes, and I think we should be able to help give some tips here. And this question is from Dr. Oreso. She says that we should distinguish between what the examiner wanted when it says list, define, enumerate, discuss. So the examiner, it may be simple, but sometimes to the candidate, discuss and describe may be a problem. So Dr. Shuaib, can you please help us? Please, so that President can take a sip of water.
As if you know. Okay, Dr. Shaibu. Dr. Shaibu, are you
Good
still
evening.
there? Good evening.
Yes, ma'am.
Okay, there's a question on the chat. I want you to tackle. The moderator has asked you to tackle it for us.
I'm also a candidate, but based on my little idea, if I can just say the way I understand it.
Okay, go ahead.
Okay, in a list and enumerate, they are almost like the same thing. So you are to just list the item. For example, if they said types or principles of anesthesia of particular So you just list it. You don't need to really talk about any detail about it. Likewise, the enumerations. In discuss and describe, there are two different things. For example, if they say discuss the anesthetic management of any case. So when it comes to discuss, you are to maybe options maybe if there are various options, you are to anesthetize a patient. There are general anesthesia, there are regional anesthesia, and local infiltrations. If it is described, you have to just take general anesthesia and describe it. You are not to discuss, you are not to describe, you are not to talk about other regional or local anesthesia. But if it comes to discuss, you would take each one of the techniques and discuss the pro and the con of each one. Why are you taking general anesthesia? What is in favor of it? What is what is not in favor of it? If you come to regional, what is in favor? So you have to discuss everything. But if it comes to describe, you are just to take one options and discuss. That's the way I was taught and the way I used to answer related question to that. Thank you.
Thank you very much, Dr.
Ivan. Yes.
Oh, Prof.
Yes.
Okay.
I think he has done well. He has nailed it. He has really made it short and simple. List and enumerate. In list, you make a list 1, 2, 3, 4, 5, 6, 7, 8. If there are 8 points, write them like that, and list it. Enumerate is the same thing. Enumerate is a numbered list. Some people, they say enumerate, they will just be putting bullets or dash, dash, dash. No. If they say enumerate, please use either 1, 2, 3, 4, or you use Roman numerals 1, 2, 3, or ABCD. Enumerate, make a numbered list. Define. Define is just say the meaning of. Define something is simple. Discuss, yes, discuss, he has told you what discuss is. You go to town, you say all the options, and describe. You describe just like if you want to describe the shape of something, you say it's tall, is dark in same shape of somebody, say it's tall, dark in complexion, it's about how many feet tall, looks like he will weigh up to 70 kg. That's describe. But discuss, you go into details, you say options, and say the different things about the options and why you choose the most suitable one, or why you say this is the one you want to use, you justify it. So that's discuss. And generally, short answer questions don't need discussing. Short answer questions are the best you just describe or you list. Short answer questions, you can answer it by defining at the beginning, that's a little introduction, then enumerating or describing. That's all, you are finished. So that's that. There's always better to submit CBT about 10 to 15 minutes to the end. That's a suggestion or a contribution by Dr. Salis Adam from IFE, that it is always better to submit CBT about 10 to 15 minutes before the end of the exam. So thank you for that input. Then Dr. Musa Zango says, for problems with computer and CBT centers, there are ICT experts going around in the exam hall And whenever you need their assistance, they are always available. So that is what I meant by invigilators. They have people specially kept to assist you on the issues with the computer. Then there's a chart by Dr.
Oshio to everyone.
Oshio to everyone. Okay.
We maybe want to pause before we go to that, man.
Okay, okay.
Because I want to ask my own question concerning the instruction to the candidates. And
okay.
Because I know we benefit from our knowledge, I want Dr. Maffei to take it. So it's about discuss and describe. So can you please explain to us, Ma, when we say discuss your and discuss the, describe your and describe the, so what is the examiner really driving at when he says you should describe your own method or describe the method of managing this particular patient, or discuss the or discuss yours? Thank you. Dr. Maffei.
Hello, Dr. Lawal.
Yeah.
Hello.
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 Hello, you
Can
are
you hear
welcome.
me?
Yes, very well.
Can you hear me, sir?
Very well.
Okay.
Yes, ma'am.
Number one, I think that was how they used to do it before, but it's moving away from that. But I must say that describe the and describe your. Describe your is what you will do if you are given this particular case. Say, for example, 30-year-old ruptured uterus, something. You will not list all the options that are available and all that. You are the one that has met with this 30-year-old with ruptured uterus. What will you do? And describe you must say the doses of the drugs you are going to use. So you can't just say, I'll use, maybe I will give ketamine for induction, followed by SOX to facilitate tracheal intubation. No. I will give ketamine for induction. I will use 1 to 2 milligrams ketamine because of the state of the patient or whatever. To facilitate tracheal intubation, I will use 1 milligram per kilogram body weight, whatever. If you are giving the weight of that patient, then you will know that they want you to state definitely the amount that you will calculate for that. So, but if you are not giving the weight, then, but you are giving 20-year-old with this, you must say what you will do. In describe, you must put your doses. In discuss, you are not touching doses at all. It's the options, just like Dr. Shuaib said, the options are available. Now, describe the and describe your. Describe the is like, we know, like, for example, if somebody has ruptured uterus and they've told you maybe blood pressure is 60/40. I'm not expecting you to tell me that you are going to use spinal for that patient. The general management that is accepted by most of us around the world is that that person is going into shock. So we're going to use something to prop him up. So I'm not expecting you to say, I'm going to use spinal, or I'm going to use epidural. That doesn't even come. So describe the. It's like we know that there's a definite way that we want this patient managed to salvage this patient. So that one I'm going to use because of this. I will use this. I will use this. I will use this. That one you don't need to mention the dose. Describe the. Okay, but describe your. You must say what you will do. What you will do. You must say what you will do in management of this patient. Discuss your and discuss this. Just the same thing again. There are several options of management for this patient, but this is what I will do. Okay, maybe this patient is coming for cesarean section. I could do options available include epidural, okay, spinal, general anesthesia, okay, local infiltration depending on how bad the patient is. However, because of this is describe your, I will do this, and then you describe what you are going to do for that patient. In the discuss your, these are the different options, but this is the one that I will take. That is the discuss yo. But the discuss, where they just say discuss D, they're just going to mention all the options available, their pros and the cons, and you are not really going to settle down for this particular way that this is how this, you just say, okay, this is available, this is this, this is this. However, because of the blood pressure, this may be favored above this other one, something like that. I don't know if it's clear.
Thank you very much. Very clear, ma'am. Thank you very much. I think the candidates must have been able to take one or two things from that. Prof, ma'am, can you please help us wrap that up so that we can go on to another thing?
No, I think I had already talked about this aspect. So maybe let's just move forward because our time, we have just 10 minutes.
Actually touch on orals, and I know candidates sometimes think when they go to orals, it's better for them to talk, and keep on talking without listening to themselves or anybody else. Or some even believe you can just go in there and just waste your 15 minutes, just say one or two things. But as long as you do not say rubbish, whatever you say is what they are going to base your mark on. Just say one or two correct things, and those things you don't know, don't talk. Is that correct, ma'am?
No, it's not so. I want us to take this question on the chat. Okay. I think I will say one or two things about oral before we finish, but we'll have just 10 minutes to go. So I want us to maximize the time. Well, what I want to also say is that we will still need another session before the exams to be able to do due diligence to these things. Orals and OSCE and long case and short case, OSCE, we have not really attended to it. So having said that, let me answer this, Dr. Osho. What's the best way to represent hemodynamic changes in the results of a dissertation, especially when the changes on each time interval have a different p-value? Is it okay to provide both the tables that provide all the p-values at the different time intervals and the figures, e.g. graphs, that give the trends clearly, or just to provide either of the two, i.e. tables or figures? Tables are not good for trends. If you have graphs, they are better. And once you have represented one result with a particular pictorial representation, that is all. You must not repeat the same result. You say this is a table, a graph showing this, and a graph showing blood pressure, a table showing blood pressure. Why? What is that? That's it's not acceptable. So, and trends are better using graphs and charts because they show it clearly. So if you have the option, please use graphs and charts, not tables. I don't really like tables for representing results of dissertations, unless if the table is very important, maybe like socioeconomic, socio-demographic variables. But generally, for me, tables are difficult to follow and don't really give much clear grasp of what you're trying to say, because you have to check this column, check this column, check this column. It's a whole lot of things. So graphs will do for me, charts will do. Most examiners, I think also, they will like you to have more charts, line diagrams, and graphs than all tables. Okay, then another question by Dr. Lukman Lawal. He said, thank you, Sazma. How do we approach a counseling session in OSCE exam? For instance, a Jehovah's Witness scheduled for elective surgery. I think in one of the last exams, I was in this session